my name is Ann Huntington. I am also a native of Idaho. I grew up in West Boise and was actually a volunteer in high school at St. Luke's, went away to the University of Utah for medical school as an Idaho student, one of the 8 spots that year. And then I came back to Idaho out after residency training and, came back home. I have been an outpatient physician, internal medicine physician, outpatient and inpatient. So in the clinic and in the hospital, and for the last 3 years have worked just in the hospital setting. Have had the pleasure of taking care of many wonderful native Idahoans, as well as many transplant folks that have come here to the state and really seen that growth. This has been a difficult couple of years for us from many different specialties and all throughout the state and the country. I just hope to give a few little snapshots of what we are seeing, a little bit of perspective, and certainly we all have different perspectives, and I value others' perspectives, certainly as they may be different from my own, and would love to learn from others. So a few things that we have experienced has been, significant growth throughout the area, as you all know, and many needs as we have tried to tackle the burden of a lot of patients coming in through the outpatient clinics, through the specialty consults, and in through the hospital. And that has been further exacerbated in the last, during the pandemic, in the last few months specifically. We have learned a lot through this time period. I will focus kind of most specifically on the past few months in my experience as an inpatient physician and a leader of about 50 hospitalists, so adult medical hospitalists, who have taken care of the bulk of COVID-19 patients, as well as in addition to our critical care physicians. We have learned some new skills. We have learned a whole new skill set as we have done this. I have heard, people say that this is just like the flu. And I will say this disease is nothing like influenza that I have seen. And I actually trained in a big H1N1 year. Where we did a lot of, ICU care and inpatient care. It's a very different disease clinically. I have never seen influenza do the things that I've seen COVID do. I have never seen this pneumonia before. And I'll give some perspective about that. I have never seen patients with stroke so readily from a respiratory virus or heart attacks in 40-year-olds who have no heart disease underlying. I've never seen so many blood clots in people with a respiratory virus or kidney failure or the neurologic issues that we've been seeing. I've never seen so much long, post-viral syndromes in my friends and my neighbors. So there's many things that this is different from any other respiratory virus that we've taken care of, and we take care of many in the hospital. It's also a different patient population. Initially, we saw, a lot more elderly patients. We saw come in with COVID last year. We saw a lot more people with medical issues. We saw a lot more people with, who had, different medical issues and reasons to be in the hospital. This most recent wave has been completely different. And as many of the chronically medically ill patients were vaccinated, as many of the elderly patients were vaccinated, we saw a whole different patient population who never normally would have been in the hospital. I know at one point our ICU patient average age was 43. And that, to get perspective, that has never happened before that I've ever seen. Where many people my age who have young kids at home and teenagers were hospitalized with a life-threatening, inflammatory pneumonia due to a respiratory virus. That has been different. We have had many folks who have didn't know they had diabetes come in and who didn't know that their obesity was putting them at risk. We have seen the effects certainly of our American diet in making people at risk for this with their immune systems. I'm a member of the American College of Lifestyle Medicine and feel that our immune system is at the key. A healthy immune system is at the key of everything that we do, and that includes a lifetime of eating healthy a lifetime of exercising and of sleeping well and of having ways to reduce stress and take care of our bodies. Americans have not been good at that, and we have not invested in public health and in those kind of preventative measures as a nation. So we are seeing the effects of that this year. And we have never seen this kind of inflammatory response in patients. I've never seen this before, where they come in very short of breath and they have COVID pneumonia already. They're in the second week of their disease after the virus has replicated for the first week. And then the immune system takes over with massive inflammation. And we do our best with the available evidence-based medications to bring down that inflammation. Many of the treatments that people are using in the outpatient setting, and to varying degrees of success, don't work in this setting, in this inflammatory setting where they go very quickly into respiratory failure. So it's a very different entity than what we've ever seen before. And it's been very humbling to take care of these folks. Just a few snapshots of what our group has been able to do and what we've done. And a lot of it has been mentioned in the public before, but we've stood up different surge units, and we've our docs, our hospitalists have been pulling 90 extra shifts per month for the past few months to be able to take care of the additional surge. So we are working far overtime to take care of these folks. We're tired. Our critical care colleagues have been doing the same. I had the opportunity to train over 100 primary care outpatient physicians on how to take care of COVID pneumonia in the inpatient setting. And this was because we knew we were going to run out of doctors to take care of all these folks. We were going to run out of inpatient doctors to take care of all these folks. It just wasn't possible to take care of that volume on our own. So we had some fantastic outpatient doctors who hadn't worked in the hospital for a long time, but they were willing to come in, learn the skill set, ask questions where they needed to, and they did a fantastic job. We have all of the research, we follow the research, we follow the information that our infectious disease providers and our committees who've reviewed the research over and over again. We have been doing that and following that to answer kind of one of the questions. We have we collaborated with many of our other specialty colleagues who work in the inpatient setting and offloaded patients to them that they could take care of so that we could focus on taking care of the COVID patients. They were very gracious in doing so. We took transfers from all across the country, oftentimes as people were trying to find inpatient beds for many of their patients. The ER doctors were calling sometimes 30 hospitals to find a place for their patient to be admitted and be taken care of. We have experienced a lot of physicians leaving medicine over the last year, and that has been concerning as those who are left have been absorbing that impact. We have had to make difficult decisions, and we have utilized our palliative care team very heavily when oftentimes these folks that have really significant pneumonia are awake and talking to you, even though their lungs are failing and they have significant hypoxia or lack of oxygen, requiring huge amounts of oxygen. And they, you just see that their lungs are not going to recover from this. It is pretty awful to watch. To reference back to influenza and some of the other respiratory viruses that we often take care of, oftentimes when people need to be in the hospital, they'll be on maybe 2 or 6 liters, sometimes more. Sometimes they'll need a ventilator. That's not very common. Sometimes they'll be on more oxygen. This is a disease that destroys the lungs very quickly, where people often end up on 30, 40 liters of oxygen per minute. It's called high flow, where it's just blowing oxygen in to keep their lungs, to keep their oxygen levels to where they need to be to oxygenate their brains. Sometimes we've had people on 60 or 80 liters. Sometimes we've had people on continuous BiPAP masks to try to oxygenate their lungs to give them a chance to survive. By the time they often need to be on a ventilator, the risk of dying is very high because their lungs are so sick and they do not recover quickly. So those are some of the things that we've seen that has been far different than anything else we've seen before. There's been a lot of, I know people trying to, when they're in this situation and they don't know if they will make it out, they need to put their affairs in order. And those are things that usually people my age don't have to do very often. And it has happened a lot more. I know that one of my colleagues has mentioned in his 25 years of practice, he has, written more death certificates than in any other previous year, and often in many years combined. So it's been a very tough year to see that, and also to see, the information that has been out in the community where, people haven't seen what we're seeing. And it is hard to be able to convey that on what we're really seeing when we can't have everybody come in the hospital and see that. So that has been difficult. I guess just trying to think if there's anything else that would be pertinent. I know that there was a life coach that spoke to a group of physicians in the last year and heard their stories. And she ultimately, is a very well-known life coach, ultimately said, I typically do coaching with a lot of military veterans, and the stories that she was hearing were very similar. And again, I would not totally equate this. There's similarities, but it is not the same experience. But she said that this was as close to those kind of traumatic situations as she had seen in many that have served in our military. This is similar to what our first responders have seen. This touches many aspects of the community for sure. Many of our nurses are therapists. I have heard of one of our ICU nurses who left was, so traumatized from what she had seen over and over again that she left being an ICU nurse and as a checker at Walmart. And that was her choice to be able to protect herself. So very, very difficult. Now we are faced with a situation where our physicians are tired, and our nursing staff is often very new. We have a lot of traveling nurses because of what has happened, and a lot of new nurses that have stepped to the plate to help out. And that does place extra burden on them and on us because they don't have the same experience that someone who has been doing that for 10 or 15 years would have. So I hope that gives a little bit more perspective on some of the differences. I know that that others have shared that in public in the community. Feel free to ask any questions as well. Thank you.